Good evening, everyone, and welcome to this special session of Seva Saturdays being hosted by Voice of Healthcare in collaboration with University of Pittsburgh Medical Center in Italy. My name is Dr. Sachin Gupta, and I'm founder of a consulting company called Salus Healthcare Resources in India. I also run an innovation hub called Whitehole Hub in Singapore, which is an accelerator for impact companies, and impact startups working out of emerging markets like India, Pakistan, Bangladesh, Philippines, and Indonesia. In today's session, the title for today's session is Leveraging Technology for Improving Clinical Outcomes in Organ Transplant. This is something which is very, very close to my heart, and I've been working in the area of clinical outcomes improvement for the last 15 years now. And we have a very special guest from UPMC Italy, Dr. Duilio Pagano, who is head of solid organ transplant at UPMC in Italy. On behalf of Salus and Voice of Healthcare, I'd like to welcome Dr. Pagano to this session. I also welcome doctors, nurses, and the members of the general public who are joining us from across the world for this session. So welcome to all, welcome Dr. Pagano. So while I talk briefly about myself and briefly introduce Dr. Pagano, Dr. Pagano, it'd be good if you can talk a bit more about yourself, UPMC in Italy, and relationship between two organizations and your team at UPMC. Dr. Pagano.
Hi, good evening, and thank you for the opportunity to be here and present our activity and present our activity during surgical activity for abdominal surgery. We are doing a lot of transplantation, a lot of surgical procedures in the abdominal organs, especially for liver, biliary tree, and pancreatic resection. So it is performed just for transplant procedure or also for surgical resection and oncologic resection for oncologic radical resection. So I have something here to share with you, like for the presentation, if you agree, because I have presented our activity in terms of surgical management of hepatocellular carcinoma. It is the base, the most important etiology and most important problem in Sicily, where we have an endemic distribution of hepatitis C virus and hepatitis B virus. So it is very important for us to face of this problem, and it is endemic in a lot of countries, probably not in every Western countries, but in Sicily it is very important because we are in the heart of Mediterranean basin. So we need to face for a lot of pathologies that are of Europe and also of North Africa. So if you agree, I can...
Sure. We'll move, I'd like to see your presentation. But before that, if you can elaborate a bit more about UPMC in US and UPMC in Italy and, the relationship between two institutions, that'd be great for interest of our audience.
Yes, I have shared the presentation. So we have a partnership with UPMC, and we are an hospital facility that perform transplantation and abdominal, but not all, also thoracic surgery and cardiothoracic surgery. And we are doing transplantation of all of the organs, from the heart to liver, kidneys, pancreas. And we was built in 1999, and it was built with the partnership from the beginning with UPMC. And now we are, this partnership was consolidated by the government of the regional government of Sicily and the Minister of Health of Italy. So now we are doing a lot of numbers in terms of transplantation, but not only. We are a reality in this part of Italy where there are not a tertiary referral center. So it is from the beginning a private hospital, but now we are a research hospital. So we are an IRCCS hospital You can find here this type of codification is for a specific hospital in Italy where we can do research. We can do also activity in terms of hospital program and health system government. So here I presented something because it is very important for us to balance between liver resection and liver transplantation. And hepatocellular carcinoma is the only tumor that can be faced with the liver transplantation. So for this problem, now we are opening new frontiers. Now we are opening a lot of new therapies and also new technologies for care the organ from the beginning, from the harvesting procedure to transplantation. So for this reason, I decided to focus on hepatocellular carcinoma and present here our data regarding this very important issue, because we can do a lot, and probably we can learn something from your experiences too for physical activity and to prepare the patient for transplantation.
Right.
And we know that this balance is very important for a choice to who is the better patient for liver resection or better patient for liver transplantation. No, the demand is very important because the supply, organ supply, is a dramatic problem also in Sicily too, also in Italy. Right. So for this reason, we decide to accept a lot of extended criteria organs, so organs from deceased donors or living donors that usually are discharged. And this patient represent a sort of benchmark patient, also for liver resection.
Right. So, okay. So you know, what kind of volumes are you catering at your center right now?
In this term, so we are performing just 70 liver transplantation per year and kidney transplantation per year. The number of lung transplantation and heart transplantation are quite reduced because there's a reality in Sicily is increasing year by year. Now we are doing 17 lung transplantation per year, something like this, but the number was quite influenced by COVID pandemic, you know.
Right. So we have seen that globally the healthcare systems are moving in direction of outcome-driven care and, you know, pay for performance, and it is very much there in US. And I have personally seen that technology and technological interventions improves clinical outcomes significantly. So when I was in Singapore, so we launched Asia's first Da Vinci robot at that point of time, and I saw that in patients on whom, you know, Da Vinci was being used, the average length of stay decreased and the complications also went down, and, you know, patient recovered very easy earlier than other patients. So similarly, there have been many new technological interventions in area of organ transplant. It would be good if you can share some of the technological interventions in recent times that you implemented and how they have led to improvement in patient outcomes.
Yeah. Thank you for this question. This is very important. And here I present, I'm showing here with this picture that is very important to study and to use technology from the evaluation of the patient. Since we need to evaluate the patient, and with a new technology in terms of the tomography or magnetic resonance, for example, in this case, for nodules of the liver that are not very well established. What is this? We are, for example, in this case with a liverets free, and is it a hepatocellular carcinoma or not? Or is it the same, for example, for a small renal tumor when we decide to have a biopsy or to decide to remove a nodule from the kidney? Or it is important just for having a nutritional evaluation before surgery, not only in terms of transplant, but also, for example, in oncologic surgery. So we need to have much more technologies to help the clinicians for decide and to discuss what is the better way for the patient from the evaluation, from preparative evaluation. So, for example, here we have in Sicily a lot of very elderly patients, and in Italy, in Tuscany, for example, we have 80s, 90s patients that are coming in our hospital and say, but I am very well, I have a good performance status. How can I do something for my life? Because I have a tumor. What can I do? So we need to choose the patient. We need to analyze better the characteristic of the patient from the beginning. So computer tomography, a new computer tomography with 3 Tesla for magnetic resonance, for example, it is very important to analyze the muscle wasting, to analyze the potential sarcopenia that is present in oncologic patient and in elderly patient, to decide what is the risk assessment, the correct risk assessment for this case. And so, for example, it is much more clear. Here we have a LIRETS-4 cancer. Here we have a LIRETS-5. So we are sure that it is an hepatocellular carcinoma. And new technologies are very important, not only for prepared evaluation, but also for surgical procedure. In this little slide, I decided to put what we are doing for liver resection, for anatomic liver resection using some new technologies, for example, the indocyanine green. Here we can define the resection, we can decide what we have to remove of this liver that is a cirrhotic liver. So we have to maintain a correct future remnant liver volume and with a good perfusion. This is the same, for example, for the lung. So before to decide, before a lung resection, we need to biopsy this lesion with a bronchoscopy or with thoracoscopy and define better what is the correct resection, for example, in an elderly patient. Or just in case of a huge tumor of the liver, just in this case, we have a major liver resection. Or in this case, for example, for liver transplantation, here you can see a liver that was removed. So after a CIRT, after radiotherapy, localized radiotherapy, as you can see here in the right side of the. For example, in this this part of the liver, and in the right side of the right of the liver, we have a shrinkage of the tumor after radiotherapy, localized radiotherapy, but the other side of the liver is perfect. So this patient was transplanted with the correct liver function, but a huge tumor that was treated before transplantation. So technology is important for have this type of activity. We have performed in 2019 100 liver resection only in 2019, and in 2020 we are influenced by pandemic. It is impossible to have not this type of influence, but we are doing just in December 2020 just 120 liver resection. So we are representing here a reality for this island, for these countries, and we are doing a lot of procedure with the technologies that was reported by UPMC expertise. So liver resection was performed with minimally invasive procedure, with a laparoscopy, with a good recurrency rate. And it is important to know that margin status is very important not only for the liver, but also, for example, for pancreatic tail, when we have to remove a pancreatic head in the pancreasectomy, and we need to decide what kind of resection we have to plan for reducing comorbidities. You say the complication, but we need to know that the patient that will be treated with a major liver or pancreatic resection will have also late complication, very late complication, not only in incisional hernia, but for example, diabetes, for example, hypertension, and other complications in terms of hormonal dysregulation. So we need to face, for example, diabetes after, now we are seeing the diabetes after pancreatic resection, because patients with chemotherapy, with biologic therapy are now living a lot. So now we are understanding that we need to face about late complication in this patient. And we need to adapt not only the surgical option, we need to adapt also the preoperative evaluation and preoperative preparation of the patient. So, for example, I have looked for a nutritional status, but also for new setting. For example, the ability to maintain a good respiratory asset and maintain a good cardiocirculatory exercise.
Right. So that's interesting. So, out of curiosity, just want to understand how's your 2-year and 5-year survival for transplant patients.
Okay.
Yeah.
For the survival, you say?
Yeah.
Yes. For the survival, we have a very long survival after transplantation for hepatocellular carcinoma. We are now in 80.5% of grafted patient survival in the first year. And when we decide to have a good survival, usually in Italy, we say that when we have a survival of 50% at the 5 years after transplantation, it is a good survival. But we have much more. We have 70 or 80%, because the real gap, for example, after transplantation, is the first year, because there is the matching with the donor, there is the matching and rejection-free survival that is now very important to be treated. But after the first year, the survival is very good. Now we have after 20 years of transplantation that are very good.
Okay, so your survival rate is one of the best in the world. So congratulations to you and your team. Yeah.
I have something here, for example, in terms of, we have no difference, for example, in terms of living donor or deceased donor liver transplantation. And you can, a living donor is very important, because a living donor does not influence the organ of deceased donors. So it is very important to note that a living donor usually has a living donor liver transplant recipient usually has a different tumors, because they had usually has a huge tumor. We decide to use the same criteria, just a Milan criteria, for deceased donor or living donor liver waiting list insertion. But in this case, if a patient has a living donor, so we can decide we can decide the strategy, we can decide the correct timing for having the transplantation. So, for example, we can decide to treat the patient with a bridge therapy and then perform the living donor liver transplantation. And this is the same for the kidneys. For example, we decide in giving the donor kidney transplantation to have a preemptive strategy, or to perform a crossover liver kidney transplantation with other kidney transplant center and living kidney transplant center of Italy, and perform the living donor liver nephrectomy, and send the kidney in another place, and decide to have another kidney that is compatible with our recipient. So the technology now is the basis, not only to have a very good communication like today with you. It is important for having the better choice, for the better matching with the patient.
Right. So that's great. So moving on to from transplant. So we want to know, our audience will like to know more about research and innovation being carried out at UPMC Italy. So in terms of clinical research, or new initiatives or innovation in medical device and technologies at UPMC Italy, if you can elaborate a bit.
Okay. In Italy, for example, in this slide, I don't know if you can see, in this slide, we decide to introduce in the clinical activity machine perfusion devices. Machine perfusion devices actually we are using hypothermic and normothermic machine perfusion devices that are very important for us for facing the enormous incidence of extended criteria donors that are present here. As you can see here, we have a number of 87% donors. And okay, we have a lot of living donor liver transplantation, but we have some problems for the deceased donor kidney transplantation. We have a few donors and a lot of patients with hepatocellular carcinoma, for example, we live in transplant waiting list. So for us, it's very important to have a support from the rest of part of Italy, and we need to wait to have an aircraft for going in another country, in the rest of the country. And we can now use, for example, non-modern machine perfusion, portable non-modern machine perfusion that can help us to reduce the ischemia time, or at least we can also not have cold ischemia time, but if we can use this device during the resting procedure. And it is very important for evaluating the organs and for evaluating the recipient, because we can wait the hepatectomy, we can wait the knife liver excision, so we can analyze better the characteristics of the patient during the hospital activities. And I wanna tell you that the ISIS can help us not only for the clinical activity, but can also help us for research activity. For example, we are now concluding, we have now concluded, and now we are reporting a clinical trial of the use of simvastatin, a drug that is usually used worldwide for reducing the level of lipid,
cholesterol, yeah,
of fatty acid in the blood. But we are now understanding that this type of organs, type of drug, can help the organs, the liver exactly, to face ischemic perfusion injury. And we are now publishing the results, and it is fantastic to know that we can not only care the liver with a machine perfusion, but we can also help the liver for reducing the damage performed during the ICU stay of the donor. And it is not only for transplantation. It is you saw just a few 3 slides ago the possibility to use green indocyanine green for localize the tumor in liver resection, minimal invasive liver resection. So it is very important because at first we need to have a correct approach with the phase 2 and the phase 3 clinical trial with the pharmacology, with the drugs, but
right.
Actually in Europe we have the EMA that approve or not some device, so can help us to decide the better device, to decide what kind of evidence based we have in some devices.
Right, great. So yeah, coming to the next part. So as you know, India is, a land of spirituality, and one of the wonderful gifts in area of medicine which India is given to world is yoga and meditation. And we have seen, centers globally where they have integrated yoga and meditation with, allopathy and, modern medicine. So clinical outcomes have improved. Are you also using yoga and meditation at your center in Italy? And how does it, improve outcomes?
I mean, it is probably a fantastic setting. It can open to us a new horizon. Right. Because we have in 25% of recipient, for example, after liver transplantation, but not only, we have a lot of psychic and energy decompensation in terms of performance status of elderly patient, of obese patient after a major liver resection. We have a 25% of a psychiatric disorder after liver transplantation. And usually it is reported, for example, in Finland, for example, in the other Western countries, are reported the 5%, the 4% of neurological psychiatric disorder per major surgery. But with an extended criteria donor, or in a patient that is not able to resolve some problems for this type of patients before surgery, I think that this type of incidence of psychiatric and neurologic disorders can result in 25 or much more incidents that is reported in Western countries.
Oh, right.
I think that this new horizon can help the naive patient. Yoga, right, can help patient before liver transplantation or before a major liver resection or before a major surgery, and can help the postoperative recovery. And I never do this, but I read a lot. And one of our consultants, Professor Bosch, usually that help us. Professor Bosch is a hepatologist now in Switzerland, before in Spain. And Professor Dr Duilio too, our chairman, is totally in agreement to adapt to introduce not only drugs, not only technology, but also new horizon for the human being.
Right. So that's interesting. So going forward, what sort of collaboration you see between, or what kind of synergies you see between, medicine in Italy and, maybe India and Southeast Asia, Asian countries like Singapore. So what is the way forward? What would be your suggestion for collaboration?
I think, thank you for this question. I think that in our facility, we have a gym. We have a gym for the postoperative recovery after cardiothoracic surgery and after abdominal surgery too. But after cardiothoracic surgery is much more fundamental. It is very important for them to have a new oxygenation of the muscle, to perform a new movimentation after a new physiatric rehabilitation after surgery, after major surgery. I think that this support can be introduced before surgery and immediately after surgery for helping patients to have an early recovery and to have a new dimension of the hospital, in a new full perspective of dimension of the new hospital. And probably the support of UPMC in terms of technology and in terms of surgical innovation could be influenced by your expertise in terms of yoga, in terms of not only for the body, but also for our mind.
Right. Yeah, so that is one interesting area. But beyond that, as you know, especially India is known as, knowledge hub of world. And this country produces the largest number of doctors globally. So do you see any collaboration between India and, Italy, or maybe between your center and, Indian centers in terms of collaboration and training of doctors? Any advice on that?
I think that one of the new cornerstones to have a strong impact in the public domain is to have this type of collaboration. Because can you imagine to have a yoga center into a transplant hospital? It could be totally strategic, not only for having a lot of patients, but also for having a new strategy that can help for restoring after surgery, and could help also the health system, government, to understand that it's important to have a new concept of the body.
Right. Okay, great. So now, our audience will like to know more about your personal interests. What do you do in your free time, and any one book which you like to recommend for your audience?
Okay. Regarding the book, I read a lot of philosophy book, and I like a lot of philosophy. So actually, I'm reading a Sicilian writer, Camilleri. Is is a writer that was passed away just 2 years ago, but he is a very important writer in Italy and in Sicily. So I prefer to read this type of book. But after the matter of medicine, I have not a lot of books to decide. After liver transplantation, after liver resection, after a lot of other procedures, it's quite difficult to have time for family and for other free time.
Okay.
Thank you for your question.
Yeah. Okay. So now, we are running out of time. So this session was very, very informative. And, I'd like to thank you, Dr. Pagano, for your time today and sharing your knowledge and wisdom with our audience. So thank you so much. And thanks to team at Voice of Healthcare and UPMC Italy team in Singapore and Italy and US. Thank you, all of you, and namaste.
Thank you. You're welcome. Thank you for this opportunity. It was important to know you.
Yeah, looking forward to work with you. Thank you.
Bye.
Bye-bye.